This video provides a brief overview of some different ways to combine and analyze data from multiple healthcare organizations. We refer to this as multi-database research. Multi-database research can increase the number of people in a study. In general, having more people in a study is better because it gives us more confidence in the results of the study. Researchers call the number of people in a study the sample size. In order to get a larger sample size, researchers may seek to combine data from multiple sources. For example, researchers from several different healthcare organizations might collaborate to answer a question that none of them can answer alone. A large sample size is especially important when what researchers are studying is rare or uncommon. Take, for example, patients who receive a medication for their rheumatoid arthritis. Questions researchers might be interested in studying are, do the patients move better after taking the medication? Or does the medication increase patients' risk of having a fungal infection? To answer these questions, researchers need to collect variables like treatments, outcomes, and covariates. Treatments are things like medications for rheumatoid arthritis or bariatric surgery procedures for severe obesity. Outcomes are things like survival, ability to move without pain, side effects, weight loss, or quality of life, things that researchers are interested in improving. Covariates are things like age, sex, illnesses, use of other medications, or other patient characteristics that could influence the relationship between treatment and outcome. Throughout the video, we will show you how data from multiple healthcare organizations can be used to answer questions like these. We will also talk about several methods that help protect individual patient privacy while still allowing researchers to answer important questions. When researchers analyze the data from multiple healthcare organizations, they often need to combine the data from each organization in one central location, or the analysis center. Each organization creates a data set of all patients who are going to be included in the study. They then send their data set to the analysis center, where it is pooled with the data sets from other organizations to create one very large data set for use for the analysis. This is called pooled patient-level data analysis. Pooled patient-level data sets contain detailed information on each patient. Each data set has one row for every patient and many columns that each contain a variable for the analysis. The variables include treatments, outcomes, and covariates. Researchers use statistical methods to measure the relations between treatments and outcomes. Adjusting for the influence of the covariates is a very important step in this process. However, because covariates often contain information that could possibly be used to identify someone, there are some barriers to sharing this kind of data between organizations. Usually, most patient information that could easily reveal a person's identity is removed from the data before it is shared. However, healthcare organizations may still have other concerns, including concerns about patient privacy and confidentiality, whether there are sufficient safeguards for data security, unauthorized uses of their data, or disclosures of sensitive information about their organizations. And some organizations may not be allowed to share patient information because of legal or contractual restrictions that prevent them from sharing patient-level data. Because of these issues, researchers are investigating alternative data sharing and analytic methods. This video is about some of these methods. One way to reduce the amount of patient-level data to be shared, but still allow researchers to take covariates into account, is to use confounder summary scores. Confounder summary scores condense information from many variables into a single number. Because these are summary scores, they have less detailed and identifiable information for each patient. Two commonly used confounder summary scores are propensity scores and disease risk scores. The propensity score for a given patient is the probability that he or she will receive the treatment being studied. The disease risk score for a given patient is the likelihood that he or she will have the outcome of interest. Both scores take into account the patient's age, sex, medical history, medication usage, and other predictive factors. Statistical models, such as logistic regression models, are used to estimate propensity scores. Cox proportional hazards models are used to quantify the relation between each risk factor and the outcome, which is then used to estimate the disease risk score for each patient. If confounder summary scores are estimated correctly, the scores will contain all the information about the variables needed for the statistical analysis. So instead of sharing detailed information on a large number of variables for each patient, researchers can share only the propensity score or disease risk score. The end result is that much less individual information is shared. Patients who receive one treatment may be quite different from patients who do not receive the treatment or who receive another treatment. This is a problem because these differences make it harder for researchers to isolate the effect of the treatment on the outcome. One way to account for these differences is to create pairs of patients that are similar to each other on some characteristics, but are different from each other on another characteristic, such as treatment. Matching treated and untreated patients on their propensity scores or disease risk scores can help researchers identify a subset of patients who are similar in many ways, but different in the treatment they receive. This allows them to determine whether the difference in treatment, such as a medication for rheumatoid arthritis, leads to a difference in patients' likelihood of getting certain outcomes, such as moving without pain. To perform propensity score and disease risk score matching, each organization estimates the propensity score or disease risk score for their patients in the study, then matches patients who receive one treatment with patients who do not receive the treatment on their estimated propensity scores or disease risk scores. Instead of requesting a patient-level data set from partners, researchers can request a data set that only includes the number of treated and untreated patients, or their total follow-up time in the study, and the number of outcome events in the treated and untreated groups. Another way to account for the differences in treated and untreated patients is to create subgroups of treated and untreated patients who have similar characteristics within each subgroup. This is called stratification. We can stratify on propensity score or disease risk score. To perform propensity score or disease risk score stratification, each organization estimates the propensity score or disease risk score for their patients in the study, then groups or stratifies these patients based on their estimated propensity scores or disease risk scores. The organization then sends to the analysis center a data set that only includes the number of treated and untreated patients, or their total follow-up time in the study, and the number of outcome events in the treated and untreated subgroups. Another method that can be used with propensity score or disease risk score is to create a risk set. To create a risk set, each organization estimates the propensity score or disease risk score for their patients in the study, then reorganizes the data from a patient-level layout to a risk set format. More specifically, you create a risk set each time an outcome event occurs. The risk set includes patients who are still in the study and at risk of developing the outcome of interest at that time point. If you want to do a matched analysis, the risk set will contain patients from the matched cohort. If you want to do a stratified analysis, the risk set will comprise patients who are in the same subgroup as the patient who has the outcome event. Instead of requesting a patient-level data set from the sites, you can request a data set that only includes risk set information. When each organization sends their data set, the analysis center can perform the statistical analysis. A final option for reducing the data shared between sites is called meta-analysis. To do a meta-analysis, each participating organization performs its own study and then shares the results with the analysis center. In meta-analysis, no patient-level data is shared. Instead, each organization sends only results about the association between the treatment and the outcome.